So, how about the positive diagnosis? First, we are going to talk about common pulmonary tuberculosis. What are the circumstances of discovery? It could be a chest X-ray done for another reason, even if the patient is asymptomatic, or a patient who is presenting trailing clinical signs. It could be general, respiratory, or extra-respiratory signs. We have first to ask the patient if he has a notion of recent tuberculosis infection, if he has antecedent of tuberculosis, about the vaccination status and the risk factors as we have seen them before. Then we ask him about the functional signs, if he had cough, dry or productive with a mucopurulent or purulent sputum, and if it is evolutive for more than 15 days. Hemoptysis. Dyspnea could be if we have an extensive lesions in the lung, and chest pain if we have an associated pleurisy or pleural effusion. Then we ask about general signs, which are very important, and sometimes we have these signs first and even before having some respiratory signs. And those signs are fever, asthenia, anorexia, weight loss, night sweats. Sometimes patient could have some extra respiratory signs, but they are low contributive because they are non-specific. So what we have to keep in mind in our country, if a patient comes to see you for a cough more than 15 days associated to general sign, you have to ask for a chest X-ray and sputum bacteriological examination looking for the Koch bacilli. At the physical examination, we have to take the weight of the patient, the temperature looking for fever. At pulmonary examination, it could be normal. We can find some bronchial rales, some crackles, a consolidation syndrome, or a pleural syndrome. At the extra-respiratory examination, we could have some adenopathy. The chest X-ray is very important to suggest a diagnosis, and we have some signs which are very suggestive for the TB. 3 signs. The first one are the nodules, which are the most common elementary radiological aspect of TB. They are small opacities with 3 to 10 millimeters in diameter, rounded or oval in shape, with clear and blurred contours, isolated or confluent. As we can see here, we have some nodules in the upper parts of the 2 lungs, and they are confluented, one next to the others. The second sign is what we call infiltrates. These are areas of general inhomogeneous opacities of variable extent and poorly defined. As we can see here, we have an opacity from the ileus to the upper part of the lung. If we compare it to the other lung, here we have nothing, and here we have this opacity. That's what we call infiltrate. Then the third sign is what we call cavern. It's an excavated opacity centered by a gaseous scalarity of variable sizes with generally regular internal contours. Sometimes it could contain hydroaeric level, and a drainage bronchus is sometimes observed. So in this chest X-ray, we can see that cavern. It has regional contours with a clarity in the center. Here we could not see the drainage bronchus, but sometimes we could see it in other chest X-rays. The other chest X-ray signs could be a consolidation like in pneumonia, or a retractile or distraction, which is located here in the upper part of the left lung, or we could have all the lung destroyed. What are the particularities of radiological lesion in TB? Those lesions can be associated. It could be unilateral or bilateral, with a variable location, upper lobe or Nelson, tendency to worsen over time, with confluence, extension and excavation, and in the advanced stages, we could have some lesions of fibrosis and destruction of the pulmonary parenchyma, like we have seen in the chest X-ray, with deformation of the mediastinal silhouette. So, any radiological lesions suggesting tuberculosis should lead the patient to undergo a bacteriological examination. We have to keep that in mind. Also, any patient with clinical signs and chest X-ray suggestive of tuberculosis, for example, if you have an excavation with a negative bacteriological examination, we should consider an alternative diagnostic. For example, a patient who is smoking and he has some clinical sign, respiratory sign, he could have fever. We have an excavation, but the bacteriological examination is negative. It could be a cancer, so we have to keep that in mind. If we have a bacteriological examination negative, we have to consider another diagnosis. So, to have a definite diagnosis, we have to look for the bacteriological examination to see the Koch bacillus in the expectoration. And those expectoration could be spontaneous expectoration. We have to take them in the morning on an empty stomach, 3 samples 2 days in a row, in a clean bottle with a tight closure to not be infected. And we have to have the bronchial secretion, not the saliva. If the patient have a dry cough, we could do what we call an induced sputum, which is done by nebulizing the patient with a physiological serum, and he will have some expectoration, and we do the examination on these expectoration. If we did that, and even with that he don't have expectoration, we could do what we call a bronchial aspiration through bronchoscopy, or a gastric aspiration through a gastric tube in the morning before eating something. In the extrapulmonary localization, if we have a pleural effusion, we can take some sample of the serous effusion fluid. If we have meningitis, we could take cerebrospinal fluid, urine, poo, and other biopsy samples. And after taking the sample, we do the bacteriological examination. The most common bacteriological examination is done by the optical microscopy. It could demonstrate these bacillus of Koch by the coloration named Diehl-Neelsen staining. We could see here the bacilli in the form of red stick. It is inexpensive, a sensitive examination, and it allows us to quantify these bacillus in a cross according to the load. We could say that we have a bacillus, but we cannot say if it is Mycobacterium tuberculosis or another mycobacteria. Its sensitivity depends on the radiological forms. If we have an excavated forms, it is very bacillary. We have sensitivity from 17 to 80%. If we have the infiltrative forms, it is less bacillifera, and its sensitivity is from 15 to 20%. And for the extrapulmonary tuberculosis, those are very paucibacillary. We could do the examination thanks to the fluorescence microscopy. it doesn't use Ziehl-Neelsen but the Oramin staining. It increases sensitivity and it reduces the time of reading. For it, we could have the result in 2 to 3 minutes. The culture is the gold standard with a sensitivity from 16 to 19% and specificity of 100%. It improves the results of direct examination. Even if we have a direct examination is negative, we could have a culture which is positive. And it's allowed us to differentiate between Mycobacterium tuberculosis and the other mycobacteria. We have several techniques. The most common and most used is the medium of Loewen-Janssen, but it has a slow growth. We need 4 to 6 weeks to have the results. And now we use more liquid mediums like MGIT, BACT alert, with a short regrowth time for 10 to 15 days. Now we have these recent years, we had what we call XPER-MTB with molecular tests. It allowed us to detect the DNA of the genome of Mycobacterium tuberculosis and their possible resistance to one of the therapy that we call rifampicin. It's an automated test, a single cartridge, a rapid result in 2 hours with high sensitivity compared to the microscopic examination. As we can see here, we have the device, the GenXpert, and we take the sample, we put it in this cartridge, and we put it on the device, and we have the results in 2 hours. If all these exams remain negative, we have some other exams that could suggest diagnosis but not confirm it, but it could help us to take a position. For example, we could have historical study, we do bronchoscopy with the bronchial biopsies or extrapulmonary biopsies, like if we have an adenopathy or a pleural effusion, we could do biopsies and we have the result epithelial gigantocellular granuloma with caseous necrosis, which is very suggestive of tuberculosis. We have also what we call immunological tests. We have 2 types of these immunological tests. First, the most common is the TST, the tuberculin skin test, or what we call intradermal reaction. We do an injection of tuberculin 0.1 millimeter, an intradermal injection in the anterior surface of the forearm, and we let it for 72 hours. Then we read it. And we are looking for the induration and the erymatous papule or even a flectin. We are talking about a positive test if the diameter of the induration is more than 5 millimeters. So when we have a TST positive, it could be either a patient who had already been in contact with Koch bacillus, a patient who is vaccinated, or patient who is having an active TB. What is the clinical interest in this case? So if a patient has a TST strongly positive, more than 15 millimeter, it is an argument in favor of TB disease. Another case, if patient had a TST before and it was negative and comes 3-4 months after and we do the TST a second time and it becomes positive, it is a tuberculosis infection. The other immunological test is what we call interferon gamma release assay, the IGRA or quantiferon TB Gold. It's the same context. We are looking for the interferon gamma in the blood of TB specific antigens. It allows us to diagnose latent tuberculosis infection and it's a guide to confirm pulmonary tuberculosis. It is not indicated in patients already treated because it will be positive and it does not distinguish between the infection and the TB disease. Its advantages comparing to the TST, it is more specific and sensitive than it, and it's not influenced by the vaccination. Another test that we could do is what we call the adenosine deaminase, which is an enzyme whose concentration increases in tuberculosis, especially in the serous. It is very sensitive and specific, with 19% of sensitivity and specificity. And when we have these ADA less than 25 units per liter in lymphocytic pleurisy, it can eliminate tuberculosis disease. So, to recapitulate all that, the diagnosis method used by the National Tuberculosis Control Program in our country, what we call Programme National de Lutte Anti-Tuberculose, PNLAT, are: for pulmonary tuberculosis, first we have to ask for the expert MTB reef. And if it is negative, we do the bacteriological examination as second line on a sputum sample, of course. For neuromeningeal TB, first we have to ask for the expert MTB reef. And if it is negative, we do the culture on the cerebrospinal fluid. And for the other extrapulmonary TB, always first the expert on the pathological product, and if it is negative, we do the culture as second line or the biopsy, the histological exam. That's what we have to say about pulmonary tuberculosis. We have other clinical forms of tuberculosis, what we call extrapulmonary tuberculosis. As we have said, all the organs can be touched by tuberculosis, but the most common are the lymph nodes and the pleura. That's why we are going to talk about them. And the two more dangerous and life-threatening are malaria and meningitis. Then we are going to talk a little bit about latent tuberculosis infection. So, first, peripheral lymph node TB. The cervical location is the most common, with 70% of cases. It could be single or multiple, and it is sometimes due to Mycobacterium bovis, as we have said before, among children with digestive infection. The diagnosis is imperative by biopsy or puncture and the expert MTB of the pew. And we have problem of differential diagnosis with other diagnosis. As we can see here, we have lymphadenopathy with some signs of inflammation. What about pleural TB? The person presents himself with general sign and with some respiratory sign like pleural type pain. At the physical exam, we have the fluid effusion syndrome, and while doing the X-ray, we can see that we have pleural effusion. While doing the puncture, we have the pleurisy is yellow and exudative fluid, and we have to do the expert MTB first, as recommended, and if it is negative, we could do the adenosine deaminase or the pleural biopsy, which can allow us to see the granuloma in 15 to 97% of the cases. As you can see here, we have chest X-ray with a pleural effusion, and we have to do the puncture to look for the fluid, to have a sample who allows us to do the examination, the MTB, the expert MTB, the adenosine deaminase, and we could do biopsy in some cases. What about miliary? Miliary TB is a type of disseminated TB. This condition is rare but life-threatening. We have non-specific clinical signs. The patient presents himself with high fever, deterioration of general condition. Sometimes he had respiratory signs, cough, dyspnea, acute respiratory failure, or even extra-respiratory signs, some digestive and neurological signs. While doing CBC, we could find pancytopenia. Pancytopenia is a low number of white blood cells, hemoglobin, and platelets. And the bacteriological research is often negative. So why we call it miliary? Because on the chest X-ray it has the appearance of millet seeds scattered through the lung. It is very common among infants and young children, more than adult and older children. And what we have to keep in mind, when we do a chest X-ray and we have miliary, if you have an associated fever, we have to think about tuberculosis first. We can see here on the chest X-ray a miliary. Those are small nodules which are juxtaposed in the two lungs. And in CT scan, we could see those small nodes juxtaposed and on the two lungs. The second form of life-threatening tuberculosis is meningitis. We have also non-specific clinical sign. We could have fever, rapid deterioration of general condition, signs of meningeal involvement, focal neurological signs, paralysis of the cranial nerves, or hydrocephalus or motor deficits. We have to do a lumbar puncture. The fluid will be clear, hypertensive, rich in albumin and protein and lymphocytes, and low in glucose. Those elements could suggest tuberculosis. It allows us to eliminate either purulent or clear fluid meningitis. And for the diagnosis of certainty, we have to ask for expert MTB as first line, as done in the other cases, but it is exceptionally positive. In second line, we have to do a culture of the cerebrospinal fluid. So, what about latent tuberculosis infection? Latent tuberculosis infection means that the tuberculous is in the body, but the immune system is keeping it suppressed and under control. And this is done thanks to the T lymphocytes, which are produced by the immune system. LTB is detected by the TST skin test and the interferon gamma, and most people who have in latent TB infection have a positive TST or IGRA result. So those patients have infection, but they do not have the disease, so they are not contagious. They do not feel sick, and they cannot spread the infection to other people. They have a normal chest X-ray, and it is important to remember that latent infection is not a case of TB. It's just an infection. So we have that table to compare between latent infection and person who had the TB disease. In the first one, we have a small number of bacteria which are under control. In the TB disease, we have a large number with active TB bacteria which is in the body. The infected patient cannot spread the disease, but patient who had pulmonary TB disease could spread the TB bacteria. The infected patient do not feel sick. This one, he feels sick and he have symptoms like cough, fever, weight loss, and others. The TST and the IGRA test are positive in both cases. In this case of infection, the chest X-ray is usually normal and here is usually abnormal. The sputum bacteriological examination and cultures are negatives in the infection and they are positive, mostly in the TB disease. This patient, in this case, we could consider a treatment for infection to prevent the TB disease, but here we have the treat the TB disease. Those patients do not require respiratory isolation because they cannot spread the TB, but in case of TB, pulmonary TB, we we may require respiratory isolation. And as we have said, it is not a case of TB, the infection. And the real case of TB is while we having a TB disease.